So today we are going to discuss about the pulse. It is one of the important component of general examination. So in addition to identifying the various pathological condition by examining the pulse, it also help us build a doctor-patient relationship. When you start checking for the pulse, you touch the hand of the patient, and this kind of build a doctor-patient relationship. In addition to identifying the various pathological condition almost related to every system, the central nervous system, the pathologies of the central nervous system. Suppose a patient is presenting to you with an RTA, road traffic accident, and you check the pulse and you find it to be a bradycardia. The patient is having a pulse rate of only say 40 beats per minute. Then suddenly you think that this bradycardia may be because of Cushing reflex, because of the extradural hematoma, which is compressing and which is raising the intracranial pressure, and this Cushing reflex has activated, which is causing bradycardia. The patient is having an altered respiratory pattern and hypertension. So the first component of general examination is a pulse. So when you start examining the patient, the first thing you take is the pulse. So what are the points we look for in examination of pulse we will discuss, but let us first look at the definition of the pulse. What is pulse? So pulse is basically an expansion and elongation. It is basically an expansion and elongation of the arterial wall imparted by a column of blood. So when the left ventricle contracts, when there is ventricular systole and ventricular diastole, this produce a pressure which is transmitted through the arteries and reach the peripheral pulses. So there is an expansion and elongation of the arterial wall which is imparted by a column of blood during ventricular systole or ventricular diastole, which produces a pulse. So what are the points we look for while examining a pulse? I gave you an example of a road traffic accident patient. Because of Cushing's reflex, raised intracranial tension, there is a Cushing's triad. What is this triad? The patient will have bradycardia, that is the pulse rate is reduced, the patient will have hypertension, and there will be an altered respiratory pattern that is known as Cushing's triad. So in every system, starting from the central nervous system, the respiratory system, the endocrine system, the cardiovascular system, the gastrointestinal system, almost every system, you can identify some pathology or you can link some pathology with the different characteristic of the pulse. Suppose a patient of hypothyroidism will have bradycardia. The patient of hyperthyroidism will have tachycardia. If the patient is having condition of the heart, the patient is having paroxysmal supraventricular tachycardia, the patient will have tachycardia. If the patient is having heart block, the patient will have bradycardia. So if there is patient of chronic obstructive pulmonary disease, there will be high bounding pulse and pulsus paradoxus. We will discuss. Patient of asthma will have pulsus paradoxus. So you have to link when you look at the patient, when you take the history, and when you start doing the examination, more importantly, the pulse. So you can link your history with the examination finding of the pulse and you can go in a line of diagnosis. So pulse is an important aspect of, or one of the most important aspect of general examination. So when you check for a pulse, what actually we look while examining the pulse are the rate. We look at the rate of the pulse. What is the rate of the pulse? It is the number of beats per minute, or the heart is beating at what rate, how much beat the heart is beating at what rate per minute is actually the rate of the, it can be more, it can be less. So the normal rate is around 60 to 100 beats per minute. If it is less than 60, it is bradycardia. If it is more than 100, it is tachycardia. Then we look for the rhythm, the rate, the rhythm. The volume of the pulse. We will discuss everything in great detail. We look for the character of the pulse. Character. There can be varying character of the pulse, which we will discuss. The delay, if there is any delay, we will discuss the condition of the arterial wall and the peripheral pulses. So let us study one by one what is the rate of the pulse. It is the number of beats per minute. Rate is actually the number of beats per minute. What is the normal rate is around 60 to 100 beats per minute, and The tachycardia, if the patient is having tachycardia, the heart will beat more than 100 times per minute. That is the tachycardia. If it is beating less than 60 per minute, it is the bradycardia. So there are different causes of tachycardia and bradycardia, vast list of causes of tachycardia and bradycardia. If you want to see here, you can see that these are the many causes of tachycardia and bradycardia. What can cause bradycardia? What can cause bradycardia or heart is beating at less than 60 beat per minute? So there are some physiological causes of bradycardia. Normally, the athlete, one who is well trained, one who is doing cardiac exercise regularly, normally the basal heart rate of that athlete or can be less than 60. That is, if the patient is an athlete, the normal heart rate can be less than 60 in athletes. And during sleep, the heart rate decreases. As we know that during sleep, the parasympathetic nervous system increases or the sympathetic tone decreases and unopposed parasympathetic activity occur which can reduce the heart rate. So normally the athletes have and bradycardia. Normally during sleep we can have bradycardia. These are the physiological conditions in which we can have bradycardia. Some drugs can cause bradycardia. If the patient is taking some drugs which is inhibiting the SA node as the impulse are generated from the SA node, if some drugs are inhibiting the SA node, mainly the beta blocker, it can cause bradycardia. So if the patient is taking beta blocker, there can be bradycardia. Digoxin and amiodarone can also cause bradycardia. Hypothyroidism, as we have discussed that hypothyroidism can cause bradycardia and hyperthyroidism can cause tachycardia. Raised intracranial pressure, raised as it is a part of an Cushing's reflex or a Cushing's triad. So if the patient is having a raised intracranial tension due to any reason, due to an space occupying lesion like tumor, due to an RTA case, if the patient is having an extradural or subdural hematoma, this can raise the intracranial pressure and the patient may have bradycardia. If the patient is having heart block, there will be a bradycardia. If the patient is having myocardial infarction, sometimes it leads to bradycardia, paroxysmal bradycardia or the vasovagal syncope. If the patient is standing or in a state of prolonged standing in a closed room, the vagal tone may increase and the patient may have syncope and bradycardia. So all the causes are not important, but some of the important causes are physiologically the patient may have bradycardia in athletes and during sleep. Hypothyroidism can cause bradycardia. Heart blocks can cause bradycardia. Raised ICT can cause bradycardia. And these are the causes of bradycardia with a regular rhythm. That means we will discuss rhythm later, so we will not concentrate on the rhythm here. So these are the important causes of bradycardia. So what are the causes of tachycardia? That is, the heart is beating at a rate of more than 100 per minute. What can cause tachycardia? Most importantly, physiologically, when you are doing exercise, you get a feeling of a palpitation, that is heart is beating at a rate of more than 100 per minute. So normally exercise or emotions can increase your heart rate and can cause tachycardia. Fever can cause tachycardia. As we know that for per degree Fahrenheit raise in temperature, heart rate increases by 10. This is normal. So suppose if I am having a normal temperature, say 98 degree Fahrenheit today, 98 degree Fahrenheit, and my heart rate is around say 70 beats per minute today with a temperature of 98 degree Fahrenheit. So if tomorrow by any reason, if I get fever because of any viral infection, because of any bacterial infection, any cause, if I get fever tomorrow, so yesterday I was 98 degree Fahrenheit and my heart rate was 70. So today I am having fever of 101 degree Fahrenheit, that is increase in 3 degree Fahrenheit. So my heart rate will increase by 30. So my heart rate today will be around 100. So for every 1 degree Fahrenheit raise in temperature, the heart rate increases by 10. This is the rule. Fever causes tachycardia. So any cause of fever can cause tachycardia. Pregnancy can cause tachycardia. Thyrotoxicosis, anemia All these are the important conditions for tachycardia. If the patient is a case of heart failure patient, the patient may have tachycardia. Drugs, more importantly, the salbutamol, the beta agonist. So the beta blocker was causing bradycardia, and beta agonists like salbutamol is causing tachycardia. Hypovolemic shock can cause tachycardia. Atrial flutter and atrial fibrillation, these are the heart condition or cardiac related condition which can cause tachycardia. Thyrotoxicosis, myocarditis are the important cause of tachycardia. So here we have seen the different causes of tachycardia and bradycardia. So normally, if the heart rate is more than 100, it is tachycardia, and if it is less than 60, it is bradycardia. So what is tachycardia? What is relative tachycardia, or what do you mean by the term relative tachycardia? When we are discussing about the rate of a pulse, more than 100 is a tachycardia, less than 60 is a bradycardia. So what do you mean by the term relative tachycardia? So if the patient is having increase in pulse rate by more than 10 beat per minute for every 1 degree Fahrenheit rise in temperature, that is relative tachycardia. And what is relative bradycardia? Relative bradycardia, as I told you, for every 1 degree Fahrenheit rise in temperature, the pulse should increase by a rate of 10. So if suppose tomorrow I am getting fever, and for fever of 101 degree Fahrenheit, but my pulse is still 90 beats per minute. It's supposed to be 100 beats per minute, but it is still 90 beats per minute. So relatively, I am having bradycardia. Yesterday I was having 98 degree Fahrenheit temperature. Today I am having 101 degree Fahrenheit. My pulse rate should increase by by 30. For every 1 degree rise in Fahrenheit, it should increase by 10. So I have raised 3 degree Fahrenheit, but my pulse rate is still 90. But it should be 100, but it is still 90. So it is relative bradycardia. So relative bradycardia, there are some conditions which causes relative bradycardia, especially the typhoid fever or the enteric fever. So first week of enteric fever will especially lead to relative bradycardia. The other infectious condition can also cause relative bradycardia, like the blood of brucellosis. Any viral infection can also cause relative bradycardia. Relative tachycardia is because of myocarditis. That means when does the relative tachycardia occur is in a condition called myocarditis. Myocarditis. So what is paroxysmal tachycardia? Paroxysmal tachycardia means the heart rate increases suddenly and suddenly it becomes normal. So in a patient of supraventricular tachycardia is a type of paroxysmal tachycardia because of an ectopic beat. So normally the SA node is producing the heartbeat. SA node is producing the heartbeat, but because of any reason there is some other extra source of production of the heartbeat that will lead to an paroxysmal tachycardia. So in a rate of pulse, we have to remember about the tachycardia, the bradycardia, what is relative tachycardia, what is relative bradycardia, and paroxysmal tachycardia. So now let us discuss about the rhythm. So discuss about the rhythm of the pulse. So what is the rhythm of the pulse? It is actually the spacing between the beat. Or it is actually the spacing between the beats. So normally, if you are getting one impulse here, the other impulse here, the other impulse here. So this is the normal. This is the normal spacing of the pulse. The space between the first and the second beat and second and the third beat is almost equal. That this is the rhythm and it should be regular. Normally it should be regular in rhythm. The pulse should be regular in rhythm. But suppose if you are getting a pulse in which the rhythm is irregular. The first beat, or space between the first beat, let's suppose this much, the space between the second and the third beat has increased. The space between the second and third beat has increased, you can see here. So the rhythm is here irregular. So in irregular rhythm, it can be either regularly irregular or irregularly irregular. What I mean by these two terms, you see the rhythm can be either regular, here the rhythm is regular, and here the rhythm is irregular. but in irregular rhythm, it is regularly irregular, which means that the first beat is coming, suppose, at a spacing, the second beat is coming at a B spacing, the third beat is again coming with a spacing, and again the second beat will come at an B spacing. So you see the distance between the first bit here and the second bit here is different, and the distance between, again the distance between the first bit and the second bit is almost same like that of the first two bit and the second two bit. So the rhythm here is regularly irregular. So what can cause the regularly irregular rhythm? Sinus arrhythmia. The sinus arrhythmia can cause regularly irregular rhythm. Why the sinus arrhythmia causes regularly irregular rhythm? So normally the heart rate decreases during inspiration. That is the sinus arrhythmia. And normally in you and me, the heart rate will decrease during inspiration. Why? Because during inspiration, what happens is that the blood coming to the right side or blood coming to the right side is more, right side of the heart is more during inspiration, and blood coming to the left side of the heart is more during expiration. So during expiration, if the pulse rate decreases, that is the sinus arrhythmia. So during expiration, the pulse decreases. During expiration, the pulse decreases. Why the pulse decreases during expiration? Because during expiration, the blood coming to the left side of the heart is more. So if the blood coming to the left side of the heart is more during expiration, there will be more stroke volume during expiration, and more stroke volume will activate the baroreceptors. The carotid and the aortic arch baroreceptor will be activated by more blood, and this baroreceptor will in turn activate the parasympathetic activity. And because of increase in parasympathetic activity or increase in vagal tone, the heart rate will decrease. So this is sinus arrhythmia, in which during expiration there is more stroke volume. More stroke volume is activating the baroreceptor, and this baroreceptor in turn is increasing the parasympathetic tone and decreasing the heart rate. So in normal individual, this sinus arrhythmia can occur in a young adult. That is because of activation of the baroreceptor, which means that during expiration the pulse rate decreases. So the rhythm will be here regularly irregular. It will be a regularly irregular rhythm, which means that the patient will have an heart rate of, say suppose during inspiration, the patient is having a spacing of this much distance, and during expiration, the patient will have a spacing of little more distance, and again this will, continue, this will continue, again this will continue during the next, again this will continue during the next, continue during the next inspiratory cycle. So here you can see that during inspiration there was a spacing, fixed spacing. During expiration, the patient is having little more spacing. So these two spacing are not matching, which definitely means that the rhythm is irregular. But it is regularly irregular because the next beat which is occurring during inspiration is almost same as that of the first beat which was occurring during inspiration. So the rhythm is irregular, but it is regularly occurring at an irregular interval. Regular rhythm occurring at an irregular interval, that is regularly irregular rhythm, which occur in sinus arrhythmia, which occur in sinus arrhythmia. And if the person is having an ectopic beat, then also we can see regularly irregular rhythm. What I mean by ectopic beat is that normally the SA node is producing the rhythm. SA node, which is located in the atria, is producing the rhythm. But if the patient is also having, suppose this is the atria and this is the ventricle. So if the atria is also having some ectopic foci which is capable of producing a rhythm. So in addition to that SA node rhythm, let's suppose this is your SA node rhythm which is occurring at a regular interval. In addition to this SA node, if suppose this ectopic foci is also producing a rhythm which is occurring after every 2 beats, then also the patient will have an irregular rhythm, but this irregularity is occurring at every regular interval. That is the regularly irregular rhythm. So these two conditions, the ectopic foci or some foci in the atria which is capable of producing a heartbeat, that is producing an ectopic beat, and that is occurring at a regular interval, can cause regularly irregular heartbeat. So there are two causes of regularly irregular rhythm. One is the sinus arrhythmia and other is the ectopic beat. The irregularly irregular rhythm. So if the patient is having an irregularly irregular rhythm, there will be no matching between the any phase when you examine for the pulse. The patient will completely have an chaotic the patient will completely have an chaotic pulse rate. So you see that there is no any regular interval occurring at this irregular pulse. So the rhythm is irregularly irregular or chaotic. So this kind of irregularly irregular rhythm occur in an atrial fibrillation, which is totally chaotic. So if you are checking for the pulse, if you are checking for the pulse, you are looking for the rate of the pulse, that is the normal how many time it is beating or the heart is beating. Normally it is 60 to 100. If it is less than 60, it is bradycardia. If it is more than 100, it is tachycardia. And we have discussed the cause of bradycardia and tachycardia, and we should think of the different pathologies with the perspective of our history and other examination finding that we will discuss later. And then we look at the rhythm of the pulse. By palpating the radial artery, we look at the rate of the pulse and the rhythm of the pulse. At what interval the pulse is being thrusting your fingers, at what interval, whether it is regular or whether it is irregular. So if it is irregular, it can be regularly irregular. That is, the spacing is having a irregularity, but that irregularity is occurring at a regular interval, that is in sinus arrhythmia and in ectopic beat. But if the pulse is totally chaotic, one beat is coming, there is a pause, another beat is coming, there is less pause, another beat is coming, there is more pause, more less pause, there is mixture of pause, that is totally chaotic pulse. That is the irregular rhythm pulse. So if the patient is having irregularly irregular pulse, one condition is atrial fibrillation. So when you are getting an irregular pulse, always you think of atrial fibrillation if you are getting an irregularly irregular pulse. And in that condition, in addition to palpating the radial artery and looking for the pulse rate, simultaneously we have to auscultate the heart and look for the heart sound and look for the heart rate directly by placing your stethoscope over the apex of the heart, and you have to hear for the heart sound, the S1 and the S2, and you have to count the heart sound. You have to count the heart sound for a period of 1 minute, and you have to count the pulse rate for a period of 1 minute. As because in atrial fibrillation, the heart rate will be more than the pulse rate, and if this difference is more than 10, it is considered to be significant, as because in atrial fibrillation, usually all the beat is not transmitted to the peripheries, to the radial artery. As there is an atrial fibrillation occurring, definitely there is a reduced diastolic time, and because of reduced diastolic time, there is less filling of the ventricle, and because of less filling of the ventricle, there may be a time where there will be a reduced stroke volume, and because of that reduced stroke volume, that reduced stroke volume cannot produce a pulse. So normally the heart rate will be more, but the pulse rate will be less. And if the difference is, let's suppose the heart rate is 120 and the pulse rate is only 100. So there is a difference of 20, which is significant. If the difference is more than 10, then it is significant. So here the difference is more than 20. So definitely it is a significant difference, which means, and this difference is termed as a pulse deficit, which means the pulse is deficit. The heart rate is 120, but the pulse is still 100. So there is deficit of 20. So this is known as pulse deficit, and it is a characteristic of atrial fibrillation. So a patient of atrial fibrillation will have pulse deficit of more than 10. And when you look for the rhythm, it will be a totally chaotic rhythm, that is irregularly irregular. So now let us describe or discuss about the volume of the pulse. So what is the volume of the pulse? So it is normally the amplitude of the pulse. It is normally the amplitude of the pulse. So what is the volume? When you look for the volume, when we look at the rate of the pulse and the rhythm of the pulse, we look in the radial artery. But when we look the volume of the pulse, we usually look in the either the brachial or the carotid artery. So remember, while checking for the rate and rhythm, we look at the radial pulse. While checking the volume and the character, we look at the carotid pulse. So this is important to know that while looking the volume of the pulse, we look at the carotid pulse, and volume actually signifies the amplitude of the pulse or the amount of blood which is reaching the artery, and that is actually the volume of the pulse or the pulse pressure. So if there is more volume, the pulse pressure is high. So what is pulse pressure? Pulse pressure is difference between the systolic blood pressure and diastolic blood pressure. So normally it is somewhere around 30 to 60. So if the patient is having systolic blood pressure of 120 and diastolic blood pressure of 80, the difference between the systolic and diastolic, that is 120 minus 80, is 40. So somewhere it is normal. So the normal can range between 30 to 60. So the pulse pressure is the difference between the systolic and the diastolic pressure. Normally it is somewhere between 30 to 60. So if the patient is having a high volume pulse, the pulse pressure will be more. Say suppose pulse pressure of 70, that patient will have a high volume pulse. If the pulse pressure is low, suppose 20, so that means that patient is having a low volume pulse. So this concept is important to understand, that when the patient goes into a shock because of any reason, either because of hypovolemic shock or because of cardiogenic shock, the pulse pressure decreases. So you are getting a blood pressure of, say suppose 80 systolic and diastolic 60. So 80 by 60, the pulse pressure difference is 20, which is less than normal. So pulse pressure has decreased. So the patient is in shock and the pulse pressure is decreased, which means that patient is in shock, hypovolemic shock, less volume is reaching the peripheries. That is why the pulse volume is low and the pulse pressure has decreased. So high volume pulse can be seen in hyperdynamic circulation like that of thyrotoxicosis, pregnancy, anemia, any condition which is leading to hyperdynamic circulation can cause high volume pulse. Very all these conditions can cause high volume pulse. The patient of complete heart block and bradycardia can also have high volume pulse. Why the patient of complete heart block will have high volume pulse? Because of heart block, there is increase in diastolic time, and because of increase in diastolic time, diastolic filling will be more, and the next subsequent contraction will produce a more ejection fraction and will have a high volume pulse. Same occurs in bradycardia. The diastolic filling time increases, the blood in the right or the left ventricle increases, and the ejection fraction increases, which will cause a high volume pulse. So the patient of hyperdynamic circulation, the patient of complete heart block, bradycardia, will have a high volume pulse. The patient of aortic regurgitation, will have a high volume pulse. Why the patient of aortic regurgitation will have a high volume pulse? Let us see it. Suppose this is your left side of the atrium and this is your left ventricle, and the left ventricle outflow is the aortic valve. So during systole, what is happening is the blood is being ejected out of the ventricle through the aorta, but the aortic valve is incompetent. So some amount of blood is reaching back during the diastole in the left ventricle because of aortic regurgitation or aortic incompetency. So there will be an extra blood in the ventricle. Because in the previous cycle, in the previous diastole, because of aortic regurgitation, some blood was reaching back in this ventricle. Normally the aortic valve should be closed after the systole, but it is not closed. and in diastole it is open, so some blood is reaching back in the ventricle, that is aortic regurgitation. So there is extra blood in this chamber, that is the left ventricle. So during the next systole, this extra blood will be pumped out, and which will produce an high volume pulse, so the patient of aortic regurgitation will have a high volume pulse. So what can cause low volume pulse? If the patient is in shock, reduced blood volume, normally the 5 liter of blood is circulating in our body. But if there is hypovolemia because of any cause, either diarrhea, vomiting, blood loss, RTA, any cause which is producing hypovolemia, pancreatitis, recurrent vomiting, diarrhea, RTA patient having hemorrhage, the patient is in shock. So there is normally 5 liter of blood circulating, but now because of blood loss or because of volume loss, the patient is having less blood, so the pulse volume will decrease and the pulse pressure will also decrease. So if you are checking for a pulse in a patient is having a pulse of, say, suppose 80/60, you think in a two-way. One is that the pulse pressure is low, a patient is having low volume pulse. So you have to think in two ways. The pulse pressure is low, indirectly the pulse volume will also be low. This is the significance of the volume of the pulse. In a patient of aortic stenosis, let's suppose this aortic valve is stenosed. So there will be less blood ejected from the left ventricle during systole. When the less blood is ejected to the circulation, obviously the pulse volume will be low. So the patient of aortic stenosis will have a low volume pulse. Same applies to patient of constrictive pericarditis or pericardial effusion, and a patient of heart failure will have a low volume pulse. Now let us discuss about the character of the pulse. The character of the pulse is defined by the waveform of the pulse. It is defined by the waveform of the pulse. So normally what is the waveform of the pulse? Let us see that how we discuss about the waveform of the pulse. So waveform of the pulse is a theoretical discussion. Normally we do not feel any waveform while palpating the pulse, because of the vascular tone, this waveform disappears, or it is not appreciated normally practically. But this is the theoretical aspects that we learn the different waveforms of the pulse. Normally there is a three wave. This is the percussion wave, this is your tidal wave, and this is your dicrotic notch, and dicrotic wave and dicrotic notch. So this is P is your percussion wave. It occurred because of ventricular systole and the blood coming and hitting the arterial wall. The T wave is the tidal wave. It is because of the reflection of blood from the wave of reflection of blood from the upper part of the body above the heart. However, above the heart, when there is systole, the blood reaching above the heart will suddenly give a jerk, and that jerk will produce, or the wave reflected from the upper part of the body will produce the tidal wave. The dicrotic wave is produced by reflection of blood or reflection of waveforms from the lower half of the body, lower than the heart. That is the dicrotic wave. And there is production of a dicrotic notch. Dicrotic notch is synchronized with the closure of the aortic valve and the pulmonary valve. So when there is closure of the aortic valve and pulmonary valve, this dicrotic notch will be produced. Not much of discussion is required for this waveform of the pulse. So normally there are percussion wave, tidal wave, dicrotic wave, and dicrotic notch. We have learned why these waveforms are being produced just theoretically. So this normal waveform of the pulse is defined as the catacrotic pulse. So this normal wave, percussion wave, tidal wave, dicrotic notch with dicrotic wave, is defined as the catacrotic pulse. So what is normal character of the pulse? Normal character of the pulse is a catacrotic pulse which have normal percussion wave, normal tidal wave, dicrotic notch, and dicrotic wave. So this much is enough for you. So what can be the abnormal character of the pulse? So normal character is the catacrotic pulse. Abnormal can be an anacrotic pulse. So what is anacrotic pulse? It is a low volume pulse with slow rising low volume pulse. So normally if you see, this was your normal pulse. Say suppose this was your normal pulse. with a percussion wave, tidal wave, the dicrotic notch and dicrotic wave. So this anacrotic pulse will be a slow rising. It will be a low volume. It will be a low volume, and it will be a slow rising pulse. So you can see that there is slowness. It will rise slowly. It will rise slowly and it will fall slowly. This is slow rising pulse, and it will have a low volume. So normal volume was at this level. So this is, or this anacrotic pulse is having a less volume, so I have drawn slightly lower than the normal volume, and it is slow rising. Normally this was an steep, but it is rising little bit slowly. So the slow rising low volume pulse is the anacrotic pulse, and it is seen characteristically in patient of aortic stenosis. As there is stenosis of the aortic valve, less blood is being ejected from the left ventricle, and this less blood will produce a low volume pulse, and this stenosed valve will eject the blood very slowly, where there will be a slow rising pulse and a low volume pulse in a patient of aortic stenosis. That is characteristically defined as pulsus parvus et tardus. Pulsus parvus et tardus. So this parvus is slow rising and tardus is a low volume. This is characteristic of aortic stenosis. Pulsus parvus et tardus, that means low volume, slow rising pulse in a patient of aortic stenosis. Water hammer pulse, we see how to check for, or we'll go to the patient and do the examination of the pulse. But water hammer pulse is seen in patient of aortic regurgitation and sometimes in hyperdynamic circulatory state. So what happened in a patient of water hammer pulse is that there is sudden rise or sudden upstroke, sudden rise of pulse, which is ill sustained, and there is sudden fall, sudden rise, ill sustained, and sudden fall. So when we check for the water hammer pulse, when we feel for the volume of the pulse, normally I told you that volume is felt in the carotid artery, but here is the exception. When we look for the water hammer pulse, we look in the radial arteries and the ulnar arteries. So the volume there will be sudden rise in volume, which will be ill sustained, and there will be sudden fall. But you have to do with a maneuver which we will discuss with the patient. So here you have to remember that water hammer pulse is seen in a patient of aortic regurgitation. So if the patient is having a twin beating pulse means there is two peak. So here you can see this was your normal pulse, which was having one beat. So in two peak, the patient will have a two peak pulse, or there will be a twin beating pulse. You can sometimes feel the double beat of the pulse during one systole. If the patient is having two peak during systole only, that is the pulsus bisferens. So what is pulsus bisferens? You are getting a two beating pulse, and that both the beat is occurring in systole. Mostly it is seen in a patient of combined lesion, that is the patient is having aortic stenosis plus aortic regurgitation. In both these conditions, you will get a twin beating pulse. And what is dicrotic pulse? Dicrotic pulse is also a twin beating pulse, but one beat is occurring in systole, and the other one beat is occurring in diastole. Other one beat is occurring in the diastole. So dicrotic pulse, one beat is occurring in the systole, the other beat is occurring in the diastole. Pulsus bisferens, both the beat is occurring in the systole. Sometimes you may get an alternate volume pulse. What do you mean by alternate volume pulse? Is that the patient is having a volume increase in volume, the next beat is increase, the next again beat is decrease, again there is increase in volume, again there is decrease in volume, again there is increase in volume, so the volume of the pulse is increasing, and every alternate beat, the high volume pulse, low volume pulse, high volume pulse, low volume pulse, that is known as pulsus alterans, alternating volume pulse. It is characteristic of acute LVF, left ventricular failure. It's important to know that the pulsus alterans is characteristic of acute left ventricular failure. But what is the catch here is that for pulsus alterans to occur, the rhythm should be normal. If the rhythm is abnormal, then you cannot say that there is pulsus alterans. Why? Because if the rhythm is abnormal, it can be because of ectopic beat. Ectopic beat, as we have discussed the ectopic beat. So if the ectopic beat is occurring, if the ectopic beat is occurring somewhere in between the normal beat, then this ectopic beat will have a compensatory pause, and that compensatory pause will have an increased diastolic filling time. And because of that increased diastolic filling time, the next beat will be slightly more. So for pulsus alterans to occur, the rhythm should be normal, and it is seen in acute left ventricular failure. What is pulsus bigeminus? There is two beat and a pause. Two beat and a pause. We have discussed it can occur in ectopic beat as well as in digitalis toxicity. If the patient is having digitalis toxicity using digoxin, the patient may have two beat and a pause, two beat and a pause. That is known as pulsus bigeminus. So what is pulsus paradoxus? Pulsus paradoxus. So we have discussed pulsus paradoxus in our earlier video. It is actually that during inspiration, normally the blood pressure decreases by 10 millimeter. During inspiration, the blood pressure decreases, but it should be less than 10 millimeter of mercury. If the decrease is more than 10 millimeter of mercury, this is known as pulsus paradoxus. Normally, why during inspiration the blood pressure decreases? It is because when we draw the ventricles here, so when we draw the ventricle here, this is your right ventricle and this is your left ventricle. So as we know that during inspiration, venous return is more, so right ventricular filling will be more. And because of right ventricular filling, this interventricular septum may impinge on the left ventricle, and the left ventricle outflow tract, that is the aortic valve or the stroke volume, may reduce during inspiration, and this reduced stroke volume will cause decrease in the blood pressure, and this decrease will be less than 10 millimeter, of mercury. This decrease in blood pressure or the systolic blood pressure, specifically the systolic blood pressure, should be less than 10 millimeter of mercury. But if this decrease is more than 10 millimeter of mercury, this is known as pulsus paradoxus. So what is pulsus paradoxus? Normally, first you understand the normal phenomena. Normally, during inspiration, the right ventricular filling is more, as because the intrathoracic or the negative intrathoracic pressure increases, which causes more venous return, and right ventricular filling is more. And when the right ventricular filling is more, this interventricular septum may impinge itself on the left ventricle, and it will reduce the space of the left ventricle during inspiration, and the stroke volume will be less and blood pressure will decrease. But this decrease will be less than 10 millimeter of mercury. But if the patient is having this decrease in blood pressure more than 10 millimeter of mercury, this is known as pulsus paradoxus, and it is seen in a patient of constrictive pericarditis. So if the patient is having constriction of the pericardium, because of constriction of the pericardium, there is already restriction of this left ventricle to expand, and further during inspiration and impingement of the interventricular septum, already there is restriction of this left ventricle to expand, so the stroke volume will decrease drastically and will cause decrease in blood pressure more than 10 millimeter of mercury. That is the pulsus paradoxus in a patient of constrictive pericarditis. So now let us see about the delay. What is the delay? So normally when we check for the radial pulse bilaterally simultaneously, normally both the radial pulse should be felt simultaneously at the same time. But sometimes you may feel the pulse of the right radial artery, but you may not feel the pulse of the left radial artery, or it will be a delay. So you are feeling this pulse with a normal volume, and you are feeling this pulse with a low volume and also having a delay. That will again signify many disease conditions. There might be some pathology to this arterial tree. If the patient is having stenosis or pre-subclavian coarctation or stenosis of the axillary artery, then there will be no blood flow to the radial artery, and we may have an absent pulse on the affected side. Or if the patient is having Takasayo arteritis, disease of the artery, then also there is inflammation and obstruction of the arteries, which will lead to reduced pulse. That is, there will be a reduced pulse on the affected side. If the patient is having aortic aneurysm or aortic dissection, then also the patient may have a radial delay or abnormal in volume of the pulse bilaterally. The patient of radiofemoral delay, you are checking for the radial artery and femoral artery simultaneously. So normally there should be no delay while filling the radial artery and the femoral artery simultaneously. But if there is delay, you must suspect one important cause, that is the coarctation of aorta. So if a young patient present to you with hypertension, normally the young individuals will not have hypertension around 18 years. A patient of 18 years old presented to you with a hypertension, you have checked the BP and BP is somewhere between 180 by 100. That is the hypertension the first time. So one important thing to consider is the coarctation of the aorta. And to look for the coarctation of the aorta, what hint you will get in examination of the pulse is this, the radiofemoral delay. You check for the radial artery and femoral artery simultaneously. If the patient is having some delay in the radial and femoral artery and the femoral artery pulse is felt with a low volume, then it signifies radiofemoral delay. That is, the patient of coarctation of aorta may have radiofemoral delay, as the blood supply to the lower limb is reduced because of the coarctation, and there is less blood supply to the lower limb. That will cause a delay pulse and a low volume pulse in the femoral arteries. Atherosclerosis of the abdominal aorta can also cause radiofemoral delay or reduced volume in the femoral pulse compared to the carotid and the radial pulse. So the condition of the arterial wall. Next important point we look is the condition of the arterial wall. What we look in the condition of the arterial wall is that if the arterial wall is thickened and have tortuous and thickened arterial wall. So normally in all individual, because of the calcification of the tunica media, if the tunica media is calcified, this is known as arteriosclerosis. This is normal aging. The arteriosclerosis is normal aging. But if the intima has calcified or undergone some plaque formation, this is known as atherosclerosis. So these two terms are different. Normally, we'll go to the patient and see how to palpate for the arteries or how to palpate the arterial wall. Normally, the arterial wall cannot be palpated, but if it is palpated, or if you can feel the arterial wall, thickened arterial wall with tortuous arterial wall, normally it can be because of either arteriosclerosis or because of atherosclerosis. Arteriosclerosis is normal aging because of calcification of the tunica media. Atherosclerosis in turn is the tunica intima plaque formation or calcification. Then after looking for the condition of the arterial wall, we look for the peripheral pulses. So what are the peripheral pulses? You can look for the temporal pulses, temporal artery. You can look for the carotid artery. You can look for the brachial artery. You can look for the radial artery, and we look for the femoral artery. We look for the femoral artery. We look for the popliteal artery. We look for the dorsalis pedis artery, and we look for the posterior tibial artery. So we'll discuss with the patient how to look for these peripheral pulses in our next session.